Hello and welcome to this video masterclass on arrhythmias and anti-arrhythmic drug therapy. My name is Russell O'Brien. I'm a consultant in acute medicine at the Royal Devon and Exeter Hospital. In this first of several masterclasses on this topic, we'll be talking about the general approach to arrhythmias, making them simpler, and also the underlying normal and abnormal electrophysiology that are important to know about arrhythmias and heart conduction. No doubt many of you will recognise this as a broad complex tachycardia, likely to be ventricular tachycardia. And as I see this, I'm reminded of a case when I was a very junior doctor of an elderly lady who's brought in critically ill in VT. She was shocked, in extremis, cold, clammy, and the intensive care unit were not keen to either sedate her for a cardiac shock or in fact admitted to the unit because she had multiple comorbidities. And I can remember feeling very challenged and threatened by this situation. This rhythm, however, is much more healthy. This is sinus rhythm. And the reason sinus rhythm's the hero of the hour, you might say, is that we get good atrial filling. We have an atrial kick that drives blood into the ventricles, and then we have an organized ventricular contraction that maintains an optimal cardiac output. And similarly, we also have good diastolic blood flow, ensuring there's no myocardial ischemia. So what about cardiac conduction itself in health? Well, this short animation will summarize what takes place. The natural pacemaker of the heart is the sinoatrial node, and a spontaneous depolarization here leads to contraction spreading across the atria. The atria and ventricles are insulated from each other, electrically at least, apart from at the AV node. And when the contraction reaches the AV node, after the atrial contraction itself, there is a short delay, after which the contraction continues down the his Purkinje fibers and the right and left bundles. And then we have an organized and rapid depolarization of the entire ventricle that allows a coordinated bellows-like output from the heart. And that's summarized here in this animation. Going back to arrhythmias, it can be very, very daunting to know what to do. And it's not helped when we look at online guidance. So this is the Resuscitation Council's management of tachycardias flowchart. And as you can see, it is pretty intimidating. There's a lot of detail, and junior and senior doctors alike will struggle to remember all of this. It's not a lot better when you look at the bradycardia one, and it's so important when you're learning when you're a junior doctor to have some better rules of thumb that you can just use and remember rather than trying to look at or memorize all of this. And that's what hopefully we'll do in this next section. So we can simplify those flowcharts in the following way. The first question really we have to ask is the patient actually ill or not? If we're answering yes to that, then we really should be reaching for equipment. And that's things like defibrillators. We'll come back to that in a second. And the first question then that we really need to know is, how do we determine whether someone's ill or not? So we need to ask ourselves, are there any adverse features in this particular patient? Are they shocked? Is their blood pressure low? Have they had any symptoms such as syncope, which may indicate there's a real threat to cardiac output? And other things like myocardial ischemia, the presence of heart failure, and also the sense that there is a very high chance that this patient's going to go on and deteriorate. So what equipment might we use for arrhythmias? Well, you'll certainly be well aware of this. For tachycardias, clearly it's ward defibrillators or defibrillators in the public environment. But don't forget also there's long-term solutions like implantable defibrillators as well. It's sometimes easy to overlook that there is equipment possible for the management of bradycardias. There's external pacemakers, temporary pacing wires, and things like permanent pacemakers as well, of course. It's something that I didn't appreciate until I actually started work, that some defibrillators actually have a pacing unit as well. So certainly when you're in hospital environments, do check out the pacemaking unit, because this can be very, very helpful in emergency situations with bradycardias. So coming back to the simplified algorithm, if we've worked out they're ill, then we're going to go and use equipment. If they're not so ill, we've got some time to think. And the big question then is, does a rhythm really need treating? There are going to be some heart rhythms that are relatively benign or well tolerated, and we can just observe and take some senior opinions on that. But similarly, there are going to be other ones where we do need to crack on, and that's where drugs and antiarrhythmic drugs come into their own. So if we go into a little bit more detail on this, which arrhythmias are the worst? Well, it's not quite a straightforward question to answer. Clearly, there's a spectrum of danger. And at one end, looking at this sort of pressure gauge or spectrum, you've got things like sinus rhythm, which clearly are completely safe, exactly what we want. You may then have some other rhythms of varying degrees of severity. And then clearly at the other end, you've got things like ventricular fibrillation, which always need the same treatment and immediate treatment as well. Things get a little murkier in the middle, and you may have, for instance, patients with atrial fibrillation, some of whom have had it for years and tolerate it, and they need no extra treatment on the day at all. But other patients with atrial fibrillation may be critically ill. So it's so important to look at how the patient is, what their comorbidities are, and then make a nuanced decision on management of arrhythmias. So you can't always apply the same rules in all these situations. And coming back to this, it's so important to look back at, is the patient ill, and using those simple barometers to determine whether you need to take action or not. So we'll move on a little bit here now. It's important to recognise what targets we have for anti-arrhythmic therapy, and I'll be talking about each of these in turn, but focusing particularly on the first one here, and that's cardiac the action potential phases. So lots of drugs will act on various stages of the action potential. But before we move on to that, let's not forget also the autonomic nervous system, and many of the drugs we use in the treatments of tachycardias and bradycardias are reliant on their effects on the autonomic nervous system. And several parts of the heart have rich innervation from these nervous systems, in particular the sinoatrial node and the AV node. Moving on to the cardiac action potential, you'll recall that this is quite similar to what happens in neuronal tissue, but it is specialized and slightly different. We'll highlight the differences here. The first thing is to look at these phases. We've got several phases to discuss. The first is phase 4. This is known also as the resting phase. And in most cardiac myocytes, this is a straight line. And during this phase, there is no ions moving across the membrane, and the action potential is steady. And it will stay that way until a neighboring cell depolarizes. And so it is reliant on a pacemaker somewhere else to drive this. At that point of depolarization, there's rapid opening of sodium channels. That's called phase 0. And there's a rapid depolarization of the membrane, which will then initiate the contraction of that cell, but also spread to neighboring cells. There's then a rapid repolarization, but that's then blunted during phase 2 when calcium channels open and there's an influx of those ions which delay repolarization, and this is also known as the plateau phase. Phase 3 is where repolarization happens and then completes and brings the action potential back to phase 4, where once again the myocyte finds itself at rest. So that's the kind of normal cardiac cycle. It's important before we look at what happens pathologically just to remember that there is a slight difference in pacemaker tissues like the sinoatrial node. Looking at this, you'll notice that phase 4 is not a straight line. And during phase 4, there is leakage of ions that actually build up to a spontaneous depolarization. And of course, this is vital for pacemaker tissue. Otherwise, we wouldn't have a heartbeat at all. So this is normal for something for cells in the sinoatrial node, but can occur pathologically, and this is a term called enhanced automaticity. And due to perhaps damage to the myocardium in infarction or electrolyte disturbances like low potassium and low magnesium, you may have cells elsewhere in the heart that develop this ability to spontaneously depolarize, and that can cause arrhythmias. So that's one reason why heart rhythm disturbances might arise. The second cause is slightly easier to get your head around, and this is something known as reentrant tachycardias or circuits. So in a circuit, you have a loop of depolarization and repolarization. So there's a wave of depolarization spreading around a circuit, and these circuits can be either tiny or massive, and they're sometimes referred to as either functional or anatomical circuits. An example of a tiny one might be that you have had a myocardial infarction, and there is a small area of myocardium that's damaged or scarred, and this circuit of depolarization moves round and round that damaged bit of heart, depolarizing the myocardium around it and causing abnormal arrhythmias such as ventricular tachycardia. But there's no necessity that the circuit needs to be small, and there are some absolutely massive ones. And a good example of that is Wolff-Parkinson-White syndrome. In WPW, as it's abbreviated to, you have what's known as an aberrant pathway. This is another connection between the atria and ventricles, separate and distant from the AV node. And in patients who have these abnormal connections, you can have a circuit that that involves almost the whole heart. A contraction may go down through the AV node normally, but then come back up through the accessory pathway and then loop back down the AV node and produce a tachycardia in that way. There are other similar circumstances to this, and we'll talk a little bit later about atrioventricular nodal reentrant tachycardias, where the circuit itself is within the AV node, and even things like atrial flutter are actually large circuits. The final trigger to abnormal rhythms are after depolarizations, and these are a little bit harder to get your head around. You'll recall from the slide just before around the normal action potential and the phases, and you'll see on this slide that there is some changes to this, and these is because during phase 3 or even during phase 4 we have what are known as early depolarizations, and these are where there is a depolarization of the membrane. And in some occasions, this might not necessarily trigger anything, but on other occasions, it may be enough to initiate phase 0 and a complete depolarization of the membrane and subsequent contractions again. These are quite common in things like long QT syndromes and in torsades de pointes. Okay, that's the end of this first part of this video masterclass. In the next parts, we'll look at the drug therapies that are used in the management of both tachycardias and in bradycardias. Thank you very much.